Knee problem is one of the biggest problem all over the world.
Yes.
So especially females in a middle age group, maybe around the post-menopausal area, many other problems associating with that can end up into osteoarthritic issues. So it is more of an aging process, which is a gradual degeneration of the knee joint. It is a major weight-bearing joint. So
Yes.
in that joint, definitely with that, over a period of time, the aging process is going to happen. Not only in India, but all over the world,
Okay.
this problem is there. Only thing is, in India, the tolerability of the pain is very significantly present. So we can see the severest of deformities, early middle age group, 40s, 50s patients. We advise them to avoid squatting and cross-leg sitting activities. So these lifestyle modifications help them a lot to prolong this disorder. So as knee joint is a weight-bearing joint,
Okay.
so over a period of time, from by birth till the age of 50s, 60s, or maybe 70s, we don't know the age group where it can end up into severe deformities.
Yes. Hello everyone, myself Dr. Amit Kamte. Welcome to Beyond Healthcare podcast. I have one friend whose granny around 60, 70-year-old, and she was not able to walk. She was not able to sit properly, and she has too many difficulties during her old age. So when we consulted a doctor, they suggested her to undergo a knee replacement surgery. And miraculously, after within a 3 days of post-operative, she start moving, and she was changed in herself only. Her depression went off, her anxiety went off, and she start living her life again. So today we are discussing a topic which is called as knee replacement, and we are here Dr. Soru. He is a specialist in a joint replacement surgery. He is going to let us go through that journey and any queries or problems the patient is facing, that all we are going to resolve today. So doctor, welcome to podcast.
Thanks a lot. Thanks for inviting me for this podcast. I'm very much overwhelmed to be here.
So actually, that's my friend's granny. She went all that issues prior than replacement, and now she is living her life a different way around. Her morbidity of life has been changed very drastically. So it is a miracle what I saw in my personal life. So can you let me know in India or in over the world the incidence of your knee replacement or joint issues the people face? And how many of them actually turn it to you or the consultant for their problems, and how the things go with them?
See, knee problem is one of the biggest problem all over the world.
Yes.
So especially females in a middle age group, maybe around the post-menopausal area,
Okay.
and many other problems associating with that can end up into osteoarthritic issues.
Okay.
So it is more of an aging process, which is a gradual degeneration of the knee joint.
Okay.
So it is a major weight-bearing joint. So
Yes.
in that joint, definitely with that, over a period of time, the aging process is going to happen.
Yes.
So not only in India, but all over the world,
Okay.
this problem is there.
Okay.
Only thing is, in India, the tolerability of the pain is very significantly present. So we can see the severest of deformities
Okay.
and severity of osteoarthritic changes,
Okay.
where the patient is very much tolerant for a very long period of time.
Okay.
So over a period of time, they feel that they again anyone who wants to go ahead for the procedure. So maybe end procedure is knee replacement, they know it. But whenever a surgery is indicated by a doctor, patient is always fearful of surgical treatment.
Okay.
So always they are maybe running away from the surgical process. So always they want to be just to wait and watch and do and manage pain as far as possible from their end.
Okay. Okay.
Yeah. So degeneration is going to happen definitely
Yes.
at any person, maybe especially in females. It is seen early
Okay.
because of the menopausal issues.
Okay.
Lifestyle in India,
Okay.
ground level activities are very significantly present in females,
Yes.
especially from by birth till the maybe mid 50s to 60s.
Mm-hmm.
So age is never a bar in this condition.
Okay.
So basically the problem arises only because of the lifestyle.
Okay.
In maybe European countries or outside India, foreign countries, developed countries, they don't have a very ground level activities.
Okay.
So maybe the deformities and the problems are not very severe,
Okay.
but the tolerability is less.
Yes.
So even with an early symptoms of osteoarthritis,
Mhm.
they end up into maybe there they know that the final treatment is surgery.
Okay.
So at that stage, definitely they think about a surgical intervention.
Okay. So, can you just let us know actually whom the knee replacement is needed?
Yeah. So see, people try all the remedies.
Okay.
Nowadays there are medications,
Yes.
painkillers,
Yes.
anti-inflammatories,
Yes.
lifestyle modifications, early age group, early middle age group, 40s, 50s patients. We advise them to avoid squatting and cross-leg sitting activities. So these lifestyle modifications help them a lot to prolong this disorder.
Yes.
So maybe we know that it is going to change up into degenerative grade 3 or grade 4 osteoarthritic changes.
Okay.
So a patient which is having tried with all kind of conservative line of management, like medications, painkillers, maybe even physiotherapy, lifestyle modifications, all kind of chondroprotective supplements, maybe for prolongation of surgery, they try another remedies like intraarticular injections, which are steroid injections, or maybe sometimes people also take give visco supplementation. So these visco supplementation gels can prolong the pain and manage it significantly. But at the end part, it is a mechanical process.
Yes.
So mechanically, over a period of time, the knee is going to degenerate and finally end up into a very bone-on-bone picture. So when we get an X-ray of a patient, which he has tried everything, and end stage definitely having very difficult lifestyle, typical waddling like a gait. So these patients with a lot of pain and discomfort in their routine lifestyle are advised for a surgery.
Okay.
But it is an advice from the doctor. Basically, it is a family decision.
Yes.
So taking that decision is the most important part.
Okay. So, you mentioned about osteoarthritis.
Yeah.
Can you just tell us what is osteoarthritis?
Yeah. So as knee joint is a weight bearing joint,
Okay.
so over a period of time from by birth
Mhm.
till the age of 50s, 60s, or maybe 70s, we don't know the age group where it can end up into severe deformities.
Yes.
So there is a cartilage between both the lower end of the femur and upper end of the tibia.
Okay.
So this cartilage over a period of time it is going to degenerate slowly.
Yes.
Some stages we feel that the X-ray is looking very good, but still the patient is having a lot of pain.
Okay.
So they have degenerative meniscal tear. That is a degenerative process only.
Yes.
And certainly they end up into locking and unlocking of the knee joint.
Okay.
So these patients can be managed with conservative therapies.
Okay.
But even when after that, over a period of time, when we get an X-ray and there is no gap between the bones. So in Indian population, we get 80 to 85% of varus deformities. Maybe we could see that the legs are bent outwards,
Okay.
and we can say typical varus deformity. Very rarely 15% we get a valgus deformity,
Okay.
where there is a lateral joint light tenderness. So the knees are knock knees kind of a feature. Yeah. So these patients significantly who are having a lot of trouble in their daily routine lifestyle, it is a very maybe life-changing thing. Maybe their mobility and activity can become very better as compared to what they are doing right now. So this is something where we advise a surgery
Yes.
when they have done all the conservative managements and still they are suffering with pain and discomfort, and where they feel that they need to take painkillers every day or maybe somewhat near about every day.
Okay. So when the patient, after the indication they saw, they have the issues, varus, valgus deformity, or severe osteoarthritis, and all that thing.
Yes.
Okay. When they come to your OPD, what things you do as a consultant when you see the patient, and how the process happen actually before going to the knee replacement surgery?
Yes. So see, it is more of a counseling.
Yes.
Nowadays, see, knee replacement can be done, but it is more of counseling of the patient having that faith on that doctor.
Yes.
So it is all about the connection between the doctor and the patient. So if they are quite comfortable to get it done and they feel that it is the patient is explained about all post-operative pros and cons about the surgery, then definitely we can indicate them for a surgery.
Yes.
So when they come to our OPD, we advise them for a standing X-rays.
Okay.
We get their X-rays done. We see clinically how is the deformity.
Yes.
Along with that, where is the pain? So
Yes.
many people have a medial joint line pain with severe deformities, and with that there are restrictions of movements. definitely they cannot do ground level activities right now. So with these restrictions and all those problems taken into consideration, and we ask them regarding this key, how is their daily routine lifestyle hampered?
Yes.
What all things they cannot do right now,
Okay.
which they were doing maybe few years ago.
Okay. Okay.
So like maybe going for a walk,
Yes.
early morning walking,
Quality of life.
yeah, quality of life, maybe cycling,
Yes.
maybe taking children in the garden,
Mhm.
going around. So these things, when the daily routine is quite significantly hampered, we
Yes.
advise them for a surgical intervention, which can definitely make them quite better as they were earlier few years ago. So that lifestyle can be brought back, and along with that, the deformities that are present, that can significantly get corrected.
Okay.
We can maybe significantly correct the deformity, which actually makes the gait pattern very normal and comfortable for the patient. But definitely we cannot advise them to go for complete ground level activities.
Yes.
Because that is again has caused the osteoarthritis.
Yes.
So even with a knee replacement, people can do, and people proclaim that they can do a squatting and cross leg sitting activities, but that is somewhat damaging your own implant.
Yes.
So we don't advise that process.
So coming up to the surgical procedure,
Hmm.
can you just tell me right now what is the modern medicine, how the knee replacement surgeries are evolved, and what is nowadays available in this century, and what is the implant actually? You said the word implant.
Yes.
So,
Implants.
yes.
So most of the patients never know what is an implant.
Yes.
They know, they exactly don't know what exactly knee replacement has
Yes.
been done.
Yes.
So see the rubbing part of the cartilage, the
Yes.
bone is actually rubbing against each other.
Yes.
There is no membrane that has been left in between
Yes.
two bones. Yes. Over a period of time, what we do is we are trying to create a gap between that both the bones.
Okay.
We are avoiding that rubbing part and putting an implant in between that.
Okay.
That is complete joint replacement.
Yes.
So there are three compartments in your knee joint: a medial compartment, a lateral compartment, and a patellofemoral compartment. We try to replace all the three compartments. That is a total knee replacement.
Okay.
Yeah. Now over a period of time, there are evolution. There are newer implants, like the implant is made up of cobalt chrome. So that is the metal. And in between two cobalt chrome materials, there is a highly cross-linked polyethylene. It is a plastic-like material where the movement happens, and the life of the implant is depending on that plastic-like polyethylene. Cobalt chrome is the standard one, but nowadays there is newer material that are coming, is maybe oxynium, that is zirconium based material, where the longevity and reaction rate is quite less.
Okay.
So these are the latest implants. Now even total knee replacement, rather than that, there are uni knee replacements, like in a younger age group in 40s, we have only unicompartmental severe degenerative changes.
Okay.
The other compartments are all good.
Yes.
We can go for a half knee replacement, that is a partial knee replacement or a unicompartmental knee replacement. We can also do for a patelloplasty. So patella, only patellofemoral compartment is involved. We can remove all the patellar osteophytes and do a patelloplasty or patellar replacement. So these implants have evolved over a period of time. Earlier the implants were very basic with standard cuts. Now with the robotics coming into picture, so robot has evolved over a period of time, and they have given a lot of newer easy ways to do a joint replacement, rather than we doing it in a conventional way and just cutting in specific angles and trying to correct the deformities. Now robot is giving us a lot of information prior to surgery. So that is the benefit of newer advanced technologies in our joint replacement surgeries.
So if somebody got decided that they want to do the joint replacement surgeries, what is the prerequisite as a person they should fulfill?
Yeah.
So go that surgery. Can you just say this?
Yeah, see, so when patients and the relatives,
Yes.
mainly the relatives, are very much concerned about
Yeah.
what happens post surgery,
Yes.
and when the problem is on both the knees.
Yes.
So they are very much concerned either to go for a one knee replacement
Yes.
or both knee replacements. So the medical problems, the medical comorbidities are very important.
Yes.
So diabetes, hypertension, thyroid,
Yes.
these things, patient is on cardiac drugs or maybe blood thinners. That again is one of the factors.
Yes.
We do a very basic routine screening that is very important in a joint replacement surgeries. We go for proper color Doppler test of the limbs to avoid any kind of deep vein thrombosis
Yes.
post-surgically. Even we do all kind of infection markers, like there should be no infection in the skin, no infection in the urine, no dental infection. All these parameters are ruled out, and then only we think about proceeding for a surgical treatment. And there are few things we do. A pre-operative scrub bath is advised 10 days prior to surgery.
Yes.
some ointment, antiseptic ointment, antibiotic ointment is given for nostrils because nasal area is the having a maximum floral count of the bacteria.
Yes.
So that bacterial floral count should be reduced during the phase of the surgery.
Okay.
So we should not end up into any kind of maybe sometimes some patients they are in the window period of some kind of an
Yes.
infection and we don't realize.
Yes.
And during that phase they might have an hematogenous spread of that infection to the joint.
Yeah.
And that is not at all maybe understood by anyone. And then it is a big trouble. So infection is one of the major troubles. So we rule out all kind of infection related problems. So dental, skin and all those things are ruled out. And then only we think about giving a surgical date.
So if the person want to choose a doctor and the facility, how would the person are there anything person should cautious about when they are going to the doctors or the facility where the operations are happening?
Yes, facility is very important.
Yes.
So in such kind of surgeries, the operation theatre is the most important thing.
Yes.
So because everything ends up into infection, and an infection can be a dreadful for a patient,
Yes.
and the patient lose complete hope after that.
Yes.
So we are trying to rule out any kind of infection.
Yes.
So operation theatre, which is definitely a modular operation theatre with a unidirectional flow of air, laminar flow air,
Yes.
and along with that we use hoods, robotic
Yes.
hood, so that our own hair and all those things, our
Yes.
infection is not gone
Wow.
when we open the joint. So those prerequisites are very important. So
Yes.
operation theatre is the most important thing.
Mhm.
Pre-operative care as well as post-operative
Yes.
care. So immediate post-operative, some patients can land up into some problems.
Yes.
So we need to have an ICU backup in
Yes.
such situations, preferably when we are thinking about a both knee replacement at one go.
Okay.
So it is a highly demanding surgery. Patients and relatives are very much,
Mhm.
they are willing for both because
Yes.
they don't want to go for the same preparation again and again.
Yes. Yes.
So if they feel that if we are planning for a surgery, we should think about getting both the knees done.
Yes. Yes.
So in such situations, the patient is the most important thing.
Yes.
So we never advise a relative that we can do both or we can do one,
Yes.
even if it is indicated.
Yes.
It is all about the blood reports,
Yes.
cardiac markers.
Yes.
So anesthetist, cardiologist, these people will only guide us. Can we do both or
Yes.
not?
Okay.
So even if we are planning for a bilateral knee replacement, if we do take a patient for a bilateral knee
Yes.
replacement, we do completely one knee replacement, close that, and
Yes.
then only we ask the anesthetist if the patient is good enough to go ahead for the second knee.
Okay.
And if even at some instance the anesthetist feel that it is not very much comfortable to proceed for that,
Mhm.
we may stop that.
Okay.
In such situations, we have done in one hospital stay 2 knee replacements,
Yes.
giving a gap of 2 days.
Okay.
So that can also be considered, seeing that blood loss is significantly present.
Okay.
In such situations, we wait for a day or two,
Mhm.
give some blood transfusion, may get the parameters better, the inflammatory markers
Yes.
lower down in a day or two
Yes.
of that knee,
Yes.
and then we can proceed for the another knee.
Okay. Okay. Patient safety is more important.
Patient safety is more important.
So coming to the anesthesia, you said,
Hmm.
which type of anesthesia generally goes with the knee replacement?
Yeah. So see, surgery is something which is bone cutting
Yes.
and putting an implant, and that implant has been fixed with cement.
Okay.
So there is a cement which has been fixed, and so there are a lot of chances of reaction of
Yes.
cement with bone.
Yes.
And in such situations, preferably we give a spinal with epidural anesthesia
Okay.
if we are planning for bilateral knee replacement. In case of unilateral knee replacement, we can also go with a plain spinal anesthesia.
Okay.
But regional anesthesia again has problems post-surgical pain management.
Yes. Yes.
So various new anesthetic blocks have come up.
Okay.
Now newer modalities are present.
Yes.
People are giving adductor canal blocks. So
Okay.
adductor canal blocks are something where they can manage only the sensory aspect. So patient has no pain post-surgically. They can walk the same day evening.
Yes. Yes.
So it is completely sensory block and motor activities are completely present.
Okay.
So patient can significantly walk on the same day.
Okay.
So that is the magic.
Wow.
So
Actually.
anesthesia plays a very important role,
Yes. Yes.
and post-surgically the physiotherapist.
Okay. So coming to the post-surgically,
Hmm.
so what happens post-operatively to the patient? Can you just let us
Yes,
know about
yes. So many people are very much concerned.
Yes.
See how many days bed rest is required
Yes.
post-surgery. So actually there is no bed rest.
Okay.
You have to immediately walk.
Wow.
That is the most benefiting surgery, and we are trying to rule out any kind of deep vein thrombosis or such kind of
Okay.
problems if we keep patient immobilized. So mobilization is the most important priority for us.
Yes, early mobilization.
Yeah, early mobilization. So as early we mobilize it is, we are ruling out all other factors.
Yes.
And preferably we advise relatives that in bed activities we start in the evening,
Okay.
or maybe next day morning depending on the pain of the patient. And next day onwards patient can stand.
Okay.
If she's comfortable or the patient is comfortable, then we can make him walk also. So it is the movements, and there is no restriction on anything. Only thing is, because during the surgery we are only changing the cartilage part, but we are actually cutting the muscle. So we are having some amount of weakness. So we advise for a walker. Initially,
Yes.
walker aided walking is advised. And hospital stay especially is only for pain management,
Okay.
as well as patient is comfortable to go to his washroom on his own.
Okay.
That is our priority. Once that is done and patient is good enough with oral painkillers and all, the next day we can discharge the patient. Preferably 3 days or 4 days is the maximum stay that we can consider for a knee replacement patient. Maybe unilateral or bilateral, maybe one more day depending on the patient. So every patient is quite different.
Yeah, definitely.
Yes.
What complication might patient face if in a replacement surgery?
Yes.
Early and late complication.
Yes. So early complication majorly can be related to the hospital acquired infections and all those problems. Even there can be a chance of deep vein thrombosis. These things can arise. There can be chances of embolism as we are using cement. Even the pre-operatively we are getting through the Doppler test and all those things. So in that test we realize that if there is some significant amount of vascularity compromise or stagnant blood flow, where there is maybe varicosity is present, so those plaques can get embolized and that can cause problems. So there is definitely a risk factor which is involved. But we do proper maybe low molecular weight heparin post surgically, so that these factors, these risk factors are completely taken out of picture. Neurovascular injuries can be present. There can be some problems, but the problems are very less. So it is a very high result giving surgery. So the result is significantly, maybe 90-95% success rate is there. So that is the only reason we can definitely confidently advise the patient that it needs, it is a very result giving surgery.
So after the surgery, how many years the benefit patient can get, or what is the long term follow up?
So patients differ. As they have their lifestyle and activities, it can be quite different. So some patients who are having very significant activities, like a farmer by occupation, they don't listen. They go and do everything. So these people might end up into early problems, but normally the company proclaims that a cobalt chrome implant will maybe for 20 to 25 years have no problem. So once, maybe preferably patient has crossed 60s, it is something which is one-time surgery. Next time we need not think about anything. If in case of sometimes age is no bar, so if the patient is having a lot of problems like in rheumatoid arthritis, inflammatory arthritis, it can end up into early problems. So in such situations, at the early age group also we do a knee replacement. In such cases we suggest an implant which has more longevity. That is the oxynium implant. So oxynium implant can be very much helpful in such way.
So after knee replacement surgery, apart from pain relief, does patient get a benefit of other benefits, like they can do running, they can do swimming, can do the normal day-to-day activity?
Yeah. So it depends on the bone quality of the patient. So in Indian population, we know that it is, most of the patients are very osteoporotic. So in such situation, that is the only reason in India we have an implant which needs to be fixed with a cement. So in foreign countries like US, and they have a very good, genetically good bone quality with low level of osteoporosis. So in those countries, they have an uncemented implant. So in uncemented implants, definitely they can do skiing, they can do jogging, they can do activities. So because the bone to bone contact is there and the bone implant interface has a good healing potential. Like in hip replacement, we put an implant which we can hammer inside the bone. Because the quality of the bone in the hip is more better. But in here, there is a cancellous bone which is majorly involved. So here, in Indian population, preferably we don't advise to do all these activities. High impact activities we don't advise. But low impact activities like walking, brisk walking, cycling, swimming, these things can definitely be done.
Okay.
Squatting, cross-leg sitting activities is depending on the patient. Some
Yes.
people may definitely be doing it. If they are doing it since ages,
Yes.
they do it, but with the due risk of maybe early wear of the
Yes.
polyethylene.
Okay.
So preferably we don't advise it.
Okay.
Some people market it in a way that I can do a
Yes.
knee replacement, a patient can squat and do cross-leg sitting activities. It is good in a way everybody who is doing a knee replacement, every patient can do a squatting and cross-leg
Yes.
sitting activities because they had done it in earlier age group.
Yeah.
But with time, if they try to do that thing, they might damage their implant earlier, which they have done for the natural knees.
Oh. So basically, ethnicity plays a very important role in the activity.
Yes, yes.
Because it is the osteoporotic changes in a knee which
Yeah.
has a long-term impact.
True. So the implant is held by the bone,
Yes.
bone and cement interface. So
Yes.
if the bone is only weak,
Yes.
we can have a high chance of periprosthetic fractures,
Okay.
injuries, if there are impacting injuries.
Okay.
Even now, some implants are having ligament preserving
Okay.
things.
Okay.
So there are ACL, anterior cruciate ligament, posterior cruciate ligament
Yes,
present
yes.
in the knee joint. Preferably, we never sacrifice our collateral
Yes.
ligaments. Medial and lateral collateral ligaments are maintained.
Yes.
But anterior cruciate ligament and posterior cruciate
Yes.
ligament, some surgeons prefer to sacrifice, and some people try to preserve PCL because that give that joint position sense.
Yes.
So preferably that is surgeon preference.
Yes.
But bone preserving thing is a cruciate retaining, that is a PCL preserving
Yes.
surgery.
Yes.
So these implants help us a lot, and maybe lifestyle is quite better. So activities can be low impact activities. They can definitely manage it.
Okay. So brisk walking and all that.
Yes, brisk walking, cycling, climbing stairs, getting
Yes.
down from
Right.
stairs, even sofa sitting, which is a very deep,
Okay.
low-lying sofa, they
Okay.
can sit and get up from there.
Yes.
So those things can be done. So preferably patients have a concern that okay, if I maybe climb stairs,
Yes.
so
Can
can
they
I climb
drive?
stairs? Yeah. Can I drive? Can I climb stairs? So stair climbing is possible.
Yes.
People don't understand. Some people say my knee replacement is failed because I cannot climb stairs. So it is not failure of the implant.
Yes.
See, surgery is doing replacing the bone surfaces,
Yes.
but the muscles are the same.
Yeah.
So we need a very good physiotherapy protocol
Yes.
post surgery.
Yes.
Preferably 1 month to 2 months good physiotherapy helps to develop a good quadriceps and hamstring muscle bulk, and that can help us to do everything without any support.
Okay. So coming to the post-surgical care.
Yes.
So as you suggested physiotherapy. So what are things are done actually in a post-surgical care?
Actually, many patients are fearful of the pain post surgically.
Yes.
So physiotherapy helps us to relieve that pain because it is more of stiffness that happens post surgically because of the scarring that is
Yes.
present.
Yes.
So exercise and physiotherapy help us to maintain the flexibility also, to gain the range of movement back also,
Okay.
and along with that increasing the strength of the muscle also.
Yes. Definitely.
So 1 month of rigorous physiotherapy and associated with that, they can definitely change their lifestyle and they can get back to complete normal lifestyle what they were as maybe few years ago.
Yes.
And pain is one of the major factor.
Yes.
So I actually explain all my patients.
Yes.
Most of the times you have seen patients, they have been operated somewhere else and they end up to some another doctor after a month or two,
Yes.
and they say that still we have pain.
Yeah.
So is our surgery successful or not successful?
Yeah.
That is one of the biggest questions.
Yeah.
Actually, we should explain our patients that I preferably try to do for my all the patients, that I explain them that 3 months to 6 months is the thing that the implant is going to adjust in your
Yes.
body. So body also is having some foreign body in your
Yeah.
thing. So body will take time to respond to that and get adjusted to that part.
Yes.
But after 3 months, or maybe rarely some patients after 6 months, they never have any issue.
Wow.
So preferably after 1 to 2 months of follow-up, patient never turn up to a surgeon except they have some major issue.
Okay. Okay. So what are the long-term complications seen in a knee replacement surgery?
Yeah, because they get better,
Yes.
they may start doing all their activities.
Yes.
There can be periprosthetic fractures
Yes.
because
Okay.
bone is osteoporotic. There can be implant loosening because the bone is weak and we have put the implant with the help of a cement.
Yes.
So the cement bone interface might weaken up
Yes.
sometimes and they might be having some pain, discomfort.
Okay.
Sometimes the ligaments may get torn.
Okay.
There can be a collateral ligament injury post surgery.
Okay.
that can end up into ligament instability and then they have issues.
Yes.
So in such situations, we have to think about a revision surgery.
Okay.
But that is all traumatic incidences. Long term can be infection or loosening. That is one of the things, but that is unpredictable. That is all depending on the patient's immunity.
Okay.
And the comorbidities like sugar and other things play a very important role.
Yes.
High HbA1c more than 8 definitely have a higher risk factor for infection. So that is primarily explained to the patient that if the HbA1c is above 8, I preferably advise them that as it is a planned surgery, preferably you go get your HbA1c corrected. At least we can wait for 6 months. We have waited for so many years. 6 months is good enough time. We don't want any complications because it is a planned surgery.
So, as you mentioned, there is a revised surgery. What is? Can you just explain a little bit about that?
Yeah. So as we told that the age of the implant, that is 20-25 years of implant life. That life is something which is again a rubbing part of the metal with the plastic, that highly cross-linked polyethylene. So as that polyethylene wears off, definitely there can be some loosening because the gap has reduced again, and again pain, discomfort. On in such situations, we go for a poly change. So we can just change the poly and come out. We can just maintain all the ligament balance and we can come out. But if by any chance we feel that there is some fracture or anything, we may have to revise completely if the implant is loosened. Those things have revision implants with the rods and cones, which will give an added stability to the metaphyseal area of femur as well as the tibia. So there are revision implants which can be treated. Means basically there is no end to that. Maybe ऐसा नहीं कि once it is done and if the patient has some issues, we cannot do anything else.
So always there is a substitute.
Always there is a substitute. There are highly modular implants which are available, which can manage most of the, even there are bone big defects also are present. We can completely replace the femur. Mega processes are available. So in case of maybe younger patients with cancer patients, we treat with such implants, mega processes. So these mega processes completely managing your bone defect.
So I just heard about minimal knee replacement surgery. Is there any difference between the minimal knee replacement surgery and traditional replacement surgery?
Yeah. So now the incision is become very less.
Yes.
Earlier they used to take a bigger incision with bigger soft tissue exposure. Even the ligaments used to be balanced very significantly with a good amount of bone. From the bone they were released, and that caused a lot of pain and discomfort post-surgically. Now the incision has been reduced.
Yes.
Even the approach to the knee joint. Now earlier, preferably many surgeons used to do only a medial parapatellar approach where they have to cut the quadriceps muscle.
Yes.
Nowadays, some surgeons who are good in that can go for a minimal invasive subvastus, which is completely preserving your quadriceps mechanism, and we need not cut the muscle. We can take completely quadriceps on one side and do a complete knee replacement surgery. Actually, the incision doesn't change much. Incision is that much only. Only the muscle which has been sacrificed. That is not sacrificed in a subvastus approach. So some people are very good in subvastus, some people are good in midvastus, or maybe some people are very much uniquely doing medial parapatellar approach. So approach is depending on the surgeon.
Yes.
But actually it is an early thing. Maybe post-surgically only 1 month that makes a difference.
Yes.
After that everything is almost similar. But the incisions over a period of time has gone very minimum, maybe hardly 8 to 10 centimeter incision is there, which is present in the anterior aspect of the knee joint.
Okay. Can you just tell us about non-surgical approaches for knee replacement which can help to relieve the pain of the patient?
Yeah. See, non-surgical approaches like an early, maybe even a young patient with early changes of osteoarthritis, with some deformities, like we know that there are knock knees, there are deformities which are present. So non-surgically we can manage them with muscle balancing, rehab, physiotherapy, exercises, lifestyle modifications that we can advise them to do. Even there are some braces that can help them to balance the weight at the knee joint. There are medial offloading and lateral offloading braces where deformity is compensated by that offloading brace. So where the weight bearing is present at that moment, that joint compartment, the load is offloaded when we are putting weight. So these braces are helpful to prolong the problem. When even with that, if the pain is persistently present, There are a few other modalities like intra-articular injections.
Okay.
We give an option to the patient. If the young patient is present, we preferably don't think about steroid
Yes.
because those are having multiple problems also
Yes.
sometimes, but preferably in the knee they do better.
Okay.
Pain relief is very better.
Yes.
But we advise them for a PRP, platelet-rich plasma therapy,
Yes.
where many people are trying to comment that it may help us the regeneration of the cartilage also. So highly potential leukocyte poor platelet-rich plasma cells.
Yes.
So we take blood from the patient only. We have a centrifuge machine, which is a different kind of a centrifuge machine, which is kept, and maybe in 15 to 20 minutes we can precipitate the plasma. The plasma is aspirated, and that highly cross-linked, basically that PRP cells are injected in the knee joint.
Yes.
Activated PRP cells.
Okay.
That helps us to manage the pain.
Is there any stem cell therapy or other exosomes are available for the knee?
Stem cells are not there. Stem cells, some people claim
Yes.
they are helpful, but in India it is not very easily available. In US and all, they get it artificially made stem cells. So definitely at them they are easily available. So they inject stem cells anywhere where they
Yes.
feel it is pain and discomfort because it is safer.
Yeah.
But in India it is not very easily available. So that is the only reason we are not very much keen on stem cells. PRP works quite well.
Wow.
Other than that, then artificially made viscosupplementations are there. The lubrication gel material. So sodium hyaluronic acid, that is what we call it, that we inject in the knee joint. That gives a wonderful result in case of maybe grade 2 osteoarthritis.
Okay.
Gives very good pain relief for at least maybe 6 months to a year.
Wow.
Along with that, lifestyle modifications we advise only.
Yes.
Muscles around the knee joint are very important. So even before surgery or after surgery, if we strengthen the muscles around the knee joint, the joint reactionary force that is generated in between the two bones, that can be significantly reduced by increasing the muscle strength around the knee joint. So these rehab modalities can help us to manage our pain.
Yes.
And if those are not there, there are some other procedures, surgical procedures like high tibial osteotomy.
Okay.
People just change the angles of the tibia
Okay.
so that the weight bearing axis is centralized.
Yes.
And in early age group we don't want to go for a knee replacement, then we can manage them with these high tibial osteotomy surgeries.
Okay. So thank you, Dr. Sarup, for coming and letting us know about what is knee replacement surgery, how it is work for us, and what are the complications, what the person has to go through the journey of knee replacement, and what precaution they have to take. Thank you.